So I'd like to introduce our speaker for today, Dr. Chris Barton. Dr. Barton completed medical school at the University of Louisville in 2014. Then he stayed with us for a child neurology residency and additional training in movement disorders at U of L. Dr. Barton joined the University of Louisville School of Medicine faculty in 2019 and is the Assistant Program Director for the Child Neurology Residency Program. He is also currently the Director of the Pediatric Movement Disorder Clinic and Norton Children's Cerebral Palsy Clinic. Dr. Barton has a specific interest in pediatric movement disorders, including Tourette's syndrome, dystonia, tremors, ataxia, and spasticity. He's also an advisory dean at the medical school, as well as the faculty mentor for the Gold Humanism Honor Society. So I'd like to turn it over to Dr. Barton, who's going to talk to us about twitches and wiggles, updates in pediatric movement disorders.
Great. Thank you so much for that introduction. And it's a pleasure to get a chance to talk to you all. And so this is a big topic, but definitely a very important one. And so I'm going to try to highlight a lot of common questions that I get in patients that I see. So first off, I have no financial disclosures, but with a lot of times in pediatric neurology, I'm going to discuss some medications that are used off-label. And I do have some videos here that are provided both from open online sources as well as a couple patient videos that I've gotten permission to use. So we'll focus on today, number one, what are pediatric movement disorders? Number two, how do we approach and classify these? And then we'll kind of run through some of the most common ones that I see with some common questions. So what classifies a pediatric movement disorder? So I have a 5.5-month-old now myself, and kids just do weird things. They do weird things all the time. I think they're almost put on this earth just to scare parents. And then they come see us. And so kids do lots of strange things all the time. And so what makes it actually a problem or something that would be classified as a disorder? So I think of four main things. So one being impaired voluntary movements. So this is, you want to do a movement, but you can't do it the right way. So this often could be something like a dystonia, dysfunction of posture. Three, the presence of abnormal involuntary movements or the performance of normal appearing movements at an inappropriate time. So think something like tics or tremor. With movement disorders in children, different than movement disorders in adults, you see a lot more Parkinson's, you see a lot more tremor, you see things like Huntington's chorea. We take care of, by far and away, the most common is tic disorders. We will see some dystonia, some tremor, as well as a couple other movements. So we'll kind of spend the bulk of our time talking about tics. I'm specifically not going to talk about dystonia today, but we will highlight some other major disorders. So looking at a couple videos here. So here's a girl who's got a number of things going on. So watching this video here, I can see that she has a lot of rapid eye blinking. She does some eye darting. She does some mouth opening type movements, all kind of while speaking. This is a guy here. He doesn't have sound, but he's got a head shaking that he does right there. That was probably a cough that if we had sound that we could see. He does some different eye rolling movements. And then this one, gosh, the kids I have who have this movement, you know, they often will get in trouble with teachers or parents or coaches. Actually, I had a coach with a kid who had a tic like this that kept making them do extra laps in practice. And so all of these are very consistent with tics. Tics, as I know, is probably something you all are seeing very commonly in your practices. These are sudden, rapid, non-rhythmic movements or vocalizations. We divide them kind of into motor and vocal or phonic tics. But the major thing to kind of remember is just any movement can be a tic. So these can be simple movements. So like you saw in a couple of those videos, eye blinking, head shaking, facial grimacing, to something much more complicated. So like hitting, I had a patient I just saw this morning who was hitting himself in the face with his tics, or tapping in weird ways, or doing some very obscene gestures. Vocal tics can range from things like sniffing and coughing. You know, we see those quite a lot. Oftentimes I'll even get referrals from ENT where patients were first evaluated for allergies or maybe started as allergies or viral infection, but then the throat clearing just continued is something very common we see. And then less common things like coprolalia. So these are like cussing tics. These are actually pretty rare. I only see these in about 2 to 5% of the patients I take care of with Tourette syndrome. But really anything can be a tic. There's a lot of things that make tics unique and kind of give us clues that this is what we're dealing with. So by definition, they wax and they wane. I kind of tell parents that parents always get really concerned. Okay, they had a tic, it went away, a new tic came up. They're worried about progression or worsening, when in reality, that's actually just the rule book. They're going to change. They're going to look different. They're going to wax and wane. That's what makes a tic a tic. And you often will get intermix of new and old tics. So we have some summer camps that our kids will go to with other kids with Tourette syndrome, and sometimes they'll trade those tics back and forth to each other. Just kind of this mix of new and old tics. I pull up this picture of whack-a-mole because that's what I like to describe to families. That tics are very much like whack-a-mole. You feel like you get one under control and then all of a sudden a new one pops up. Much worse with stress, anxiety, excitement, anger, infection. Right now, all my kids are doing pretty good with their tics because it's summertime, but tics will get a lot worse during periods of change. So when school starts, when school ends, with state testing, I see it happen a lot more with holidays, not because kids are anxious about the holidays, but more they're excited with anticipation. So the tics become a little bit more noticeable. And the more you talk about it, the more they will show up. And it's very common when kids are focusing on other things. So I see this a lot where if kids are watching movies or they're doing video games, parents will come to me because they're in baseball, and when they're on first base, just sitting there, their tics will increase. This again is just kind of a rule of thumb. And then one thing that is very specific for tics that can be really helpful is this urge or this sensation. So it's this feeling kids get before they have a tic. It's much more common to have urges when you're an adult. So typically I start seeing urges come up in kids that they can articulate to me about 8 to 9 years of age, whereas young kids, it's not as common. Some other ways that I ask is like, hey, do you get a feeling before your tics? Or, hey, can you control your tics for, even 5 seconds, 10 seconds? And if they say yes, I say, how come? Like, how are you able to know there's something I need to control here? And usually that's pretty helpful for me to kind of find that part out. Talking about different tic disorders. So I'll talk mostly about provisional and then Tourette syndrome. So provisional tic disorder are motor and vocal tics that happen for less than a year. We used to call this transient tic disorder. The DSM-5 changed this because, okay, if you have transient tics for 364 days, you have transient tic disorder. And on that 365th day, you have Tourette syndrome, which was kind of silly. So provisional means I'm provisionally giving you this diagnosis until we have time. And what we know about with provisional tic disorder, it's actually really common for the tics to come back in the future. So kids who have provisional tic disorder, only 1/3 of them actually have total tic freedom, never have tics again over the next 5 to 10 year period. So if I see provisional tic disorder, I'm often counseling or treating it similar to Tourette syndrome, just in terms of how I talk to families. You can have motor and vocal tics by themselves, and then Tourette syndrome specifically means 2 motor tics and 1 vocal tic with no tic-free periods longer than 3 months. You don't necessarily have to have the same tic during that time, but no tick-free periods longer than 3 months. And it has to start before the age of 18. Usually I get a little suspicious that I'm thinking about something else if it's before age 12. Now I will see some teenagers who come see me where if you really talk to them, they maybe had some transient tics that came at around 5, 6, 7 years of age and went away, and now they've come back up. I'll also talk here a little bit at the end about some these new tic disorders we've seen in the last 1.5 years, if anybody has seen any of those patients. Prognosis and progression. So tics tend to peak between ages 8 to 12. So that tends to be the peak age. It's much more common in boys and girls. Tourette syndrome is 3 to 1 boys and girls. And it is not uncommon to kind of have a start with an infection or with a medication change. And again, kind of waxes and wanes based on stress. The number one question I get is, what does this mean long-term? And prognosis long-term is extremely good. So a third of adults who have Tourette syndrome as a kid have 0 tics. A third of them, their tics just improve pretty substantially. And then a third of them stay the same and get worse. And only 10% of adults who had Tourette syndrome as a kid need medication for their tics as an adult. So it's very much limited to being in kids. The biggest thing with Tourette syndrome and when I see patients is thinking about comorbidities. These are important because with Tourette syndrome, comorbidities are really common, and comorbidities can sometimes be more problematic than the tics themselves. And 86% of patients will have at least one comorbidity based off the literature. And it's really uncommon for me to see a patient that doesn't have at least one of the things we're about to talk about. And it's important because with the comorbidities, when those get out of whack, that can make the tics a lot worse. So sometimes the best tic treatment is actually good control of the comorbidity. So what am I talking about? I'm talking about things like ADHD, things like anxiety, things like learning disabilities, speech delay, OCD, which isn't listed here. But all of those are big comorbidities that are important to screen and recognize in these patients. This is, I love this diagram. I think this is a perfect way to think or talk about Tourette syndrome. This is from the Tourette Association of America website. And I pull this up with almost every tic patient that I see just to kind of talk about what we're dealing with. So I like to tell parents that the top of the iceberg, the vocal and motor tics, are why kids come to see me. But it's all the stuff under the iceberg that causes kids the most problems. So things like I said, ADHD, OCD, anxiety, bullying, rage attacks. So kids just getting upset and not really knowing why, sleep issues, handwriting difficulties. A lot of patients have unrecognized handwriting difficulties. And you can imagine that being very difficult in that 6, 7, 8-year-old range when you get graded on these type of things. It's very important to kind of look at these. And again, if these are causing kids problems, that oftentimes it can make symptoms worse. And in my younger kids, so again, 5, 6, 7, 8, I also often tell them that with tics, most of the time, the tics don't cause kids problems. Tics at that age tend to not bother kids as much, but often bother parents and teachers. And so a lot of education and a lot of reassurance is a big part of taking care of these patients. Now, one specific comorbidity, ADHD, is extremely common. And so I get this question quite a lot in patients with ADHD. What should I do about using stimulants or using ADHD meds? So as we know, there's been a number of studies that have shown that stimulants tend to not cause tics, but they certainly can unmask them. But what else does the data say about tics? So there's been 3 major randomized control trials. One that was done in methylphenidate versus placebo at 3 different doses. They used 2 different scoring systems. One was a Yale tic severity scale, which basically looks at how much the student is feeling problems related to their tics. And the second being the teacher global tic score, which is the teacher basically assessing how common they think their tics are happening. And this study actually showed that versus placebo, methylphenidate made the teacher scale improve. So even it actually showed that tics got better. In a similar way, this study was an interesting study where they took methylphenidate and dextromethorphan at 3 different doses versus placebo, and every patient got at least both drugs at each of the different doses. And they saw that there was no difference in tics versus placebo with any of them except for dextroamphetamine at high doses. And then the third study looked at clonidine with methylphenidate versus methylphenidate versus placebo. And all of the groups, whether it was clonidine alone, methylphenidate, or combined, improved the Yale Tic Severity Scale versus placebo. So that's a lot of data to tell you, hey, what do we take away from this? I take away, number one, that a lot of studies have shown that stimulants can actually improve tics. So don't be afraid to consider stimulants in your patients. I always counsel it could unmask tics or make them worse just for a small period of time to get better. And stimulants can still be used, but need to be monitored closely. So my rule of thumb, so this is kind of a highlight point here, is if you can use stimulants, if you're going to do it, start low, go slow. Often methylphenidate derivatives based off the data may be a little bit better than dextroamphetamine derivatives. But if you have side effects or tics happen, then switch to a different class of stimulant or switch to a non-stimulant ADHD medicine and trial that. But definitely you can use it and just kind of see how patients do. So how do we treat tics? I'd say about 60 to 70% of my patients, we can just education, watchful waiting, counsel on tics, counsel on that it's normal. The biggest thing that I find is a lot of parents are just nervous about their own experiences or social media stigma when it comes to tics, and that they don't want that for their children. And so just educating, and that can involve education for the parents, that can involve education for the kid. Sometimes I have to provide education for schools or teachers. And the Tourette Syndrome Association of America does a really good job at advocating for patients and can even do school-based visits if needed as well. And then I'll watchful wait, particularly in my younger kids. I tend to follow them during that kind of peak period and just making sure that we're not having any worsening symptoms. And then there are some therapy and medication options. So when we talk about doing therapy or medication, the way that I approach treatment is, number one, identify the most severe comorbid condition. Again, if the anxiety is in a child is what is causing the most problems, anytime their anxiety acts up, their tics are going to act up. So it's really important to kind of focus a lot of that energy on anxiety, and oftentimes you'll make the tic much better. I try to only treat with tics that are functionally disabling and not remedial to different interventions. And so some of the criteria that is published to treat is things like loss of self-esteem, peer problems, difficulty with participating in academic or schoolwork or home, and then or if it's causing pain. So you can imagine if kids have head jerking tics, that can sometimes cause some neck pain or discomfort. Oftentimes in those cases, I'll treat too. Anytime I treat, particularly when I'm using medicines, I always counsel the goal is to not make tics go away. A lot of families want the tics to go away completely, and so you'll just kind of keep raising medicines. But the goal is not to cure tics. Tics aren't harmful, but to make tics to where they don't interrupt that quality of life. So I always counsel and make sure that people understand kind of what are our goals. With behavioral-based therapy. So I'm going to put a reference here and a couple slides for the 2019 American Academy of Neurology Tourette Syndrome Guidelines. So they published these Tourette Syndrome treatment guidelines, and the only level A evidence for treatment was with CBIT or CBIT. And CBIT stands for Comprehensive Behavioral Intervention for Tics. This is really neat. It's a kind of a combination of cognitive behavioral therapy and habit reversal therapy, and can often be first line. Now, that comes with a caveat. So what CBIT does is it treats kids to recognize that urge, and then when they feel the urge, to come up with a counter tic or an opposite tic, what we call a competing response. So a good example may be if kids have a coughing tic, so they kind of feel a scratch in their throat and they cough. One CBIT strategy our occupational therapists will use is to maybe have them put their tongue on their roof of the mouth and make a circle for 5 seconds. And so they're basically training yourself to have that urge and then come up with some opposite competing response that fills that urge without doing something disruptive. So in order for it to work, number one, they got to have an urge. Number two, they've got to want the tic to go away. I know that sounds silly, but some kids actually like their tics, or they find their tics comforting. And so they've got to want the tic to go away, and you've got to focus on one at a time. And this isn't a criteria, but I also find that kids have to be able to kind of cognitively sit and pay attention. So sometimes my younger kids with uncontrolled ADHD, CBIT just isn't something they're able to participate in. Most of the time, I can start talking about CBIT in kids over 8 years of age. Rarely we'll have kids who maybe have urge under 8, but 8 is kind of a nice cutoff to think about. It is performed by occupational therapist and focuses on becoming, 1, more aware of the tics, 2, developing those competing responses, and then 3, recognizing triggers. So maybe certain things that make you anxious and make the tics come more, what can we change to make that reduce? CBIT is done by a couple different people throughout the state. So we have providers through Norton. Spalding University has a really nice program, as well as associates in pediatrics therapy. There's also an online-based source for some of you that are maybe in more rural areas. The Spalding University group does provide telemedicine for patients, but there's also a resource called tichelper.com that has independent CBIT providers. And then we often make these referrals too. So if you have a patient that you think may be amenable to this, that you can refer to these people, or definitely refer to us. We can evaluate and see if we think they qualify, and then help facilitate that. With medications, so medications, now I'm going to talk about a couple of medications here that are off-label. So the very first one that I tend to use in most patients are alpha-2 agonists. This is particularly effective in patients who also have comorbid ADHD. This is kind of first line. These patients have fewer side effects. And often, if they do have side effects, mostly sleepiness, lightheadedness, lower blood pressure. With guanfacine particularly, which I use a lot of, I have found just in my practice that patients tend to really tolerate the extended release formulations. And then you also want to think about, hey, the goal here isn't to make the tics go away. The goal is to try to make life go on. So you want to start low, go slow, slowly titrate to try to avoid side effects. Now, this does get a little tricky if you're using guanfacine both for ADHD and for tics. Sometimes you do need to be a little more aggressive in those cases. Topiramate actually has some really nice evidence for the use. And so particularly in patients I have that have Tourette syndrome and epilepsy, or Tourette syndrome and headaches, I will use a lot of topiramate. You can also use dopamine blockers. These are the ones that have been shown to be the most effective, with aripiprazole being FDA approved, haloperidol being FDA approved. I tend to use these very rarely though. Oftentimes patients can't tolerate it, or it has pretty severe side effects. So I use these just with my most severe patients with Tourette syndrome. And then there's a couple other options down the line. So one is VMAT2 inhibitors, which are a new class of medicine. Right now it's very expensive and not FDA approved. There's a new medicine that be on the lookout probably in the next couple of years that they just presented at the American Academy of Neurology meeting in April, called ecopipam, which is a D1 antagonist. So our traditional dopamine blockers are D2. So these is a D1 antagonist, tends to not have the extrapyramidal side effects or weight gain associated. So this may be a good option for patients in the next couple of years, but currently is not on the market. Botulinum toxin can be used, particularly if you've got muscle aches or pains with motor tics. In rare cases, I've used that. I did not put that here, but I've also used baclofen. There's some good evidence for baclofen. So in patients that have a lot of pain associated with their tics, I will sometimes try low-dose baclofen. And then in adults, so not in our population, but deep brain stimulation has been seen to be effective. We'll never use that in kids because most kids will grow out of it. But that's something that can be done in adults. This is something if you want to save, this is a published algorithm from Jankovic, who's a movement disorder specialist at Johns Hopkins, and is basically a very similar approach to how we approach kids. So if you think that, okay, they have tics, but they're otherwise doing well, they don't necessarily need to be referred. But if you feel like, hey, this is starting to cause functional impairment, or I'm worried about something else going on, definitely refer. We are happy to see the patients for sure. And then, like I referenced earlier, this is the practice guideline. So this has a nice kind of 3 or 4 page handout that's good to have as reference if you want to view that. So now we're going to change from talking about tics and Tourette syndrome to talking about other things that can look like tics and a couple other specific movement disorders. So lots of things can look like tics. And a big part when I see patients with tics is I'm trying to make sure I'm not dealing with something different. So habits or mannerisms, stereotypies, OCD. So OCD can be really tricky because kids can have OCD and Tourette syndrome. The big difference between OCD and so OCD meaning you have a compulsion. So a compulsion meaning I need to wash my hands 15 times. Sorry, an obsession where I need to wash my hands 15 times, and a compulsion, you act on it, similar to an urge. I've got a scratch in my throat and then I have to act on it with a tic. Some of the differences, because the treatment is different, is that with obsessions and compulsions, one, it's not a sensory feeling as much as a complex thought. So it's not like I've got a scratch in my throat, it's a more complex thought. And two, there tends to be some bad sense of impending doom. So if kids don't do their tic, they may just feel bad or feel a little anxious. But people who don't do their compulsions after their obsessions, they often will worry something very severe will happen. And then we'll talk about a couple of these others here in a minute. So a couple different videos here. So one, this is a very cute girl with a cat shirt on who's doing a couple of things. So she's doing some kind of hands out to the side. She's doing some hand wringing, hand flapping type movements up near her face. She clearly looks like she's having fun and playing outside. There's a trampoline next to her. This is another girl who's doing a couple of things. She's jumping up and down. She's bringing her hands really close. She's playing with her hands back and forth. She's doing some hand flapping. And then this child here is doing a couple of things. So the hands up close to the body, kind of shaking back and forth. Again, all 3 of these are showing some sense of excitement. And these are stereotypies. So stereotypies is a very common mimicker of tics that I see. There's a couple of things that distinguish it, which we'll talk about in a second, but they tend to be very repetitive and fixed. So unlike tics that change or become different, stereotypies are fixed. They tend to not be an urge, and they almost always start before 3 years of age. So families will say, hey, they've always done this. And you can have stereotypies and tics together, but this is what a stereotypy will look like. They tend to occur in bursts, and often through, I like to say, periods of engrossment. So like super excited, super stressed, super bored, super fatigued, sometimes if they get scared, and can happen many times a day. Again, you want to rule out other disorders here, and then distinguishing them from tics. So tics tend to start later. So 4 to 8 years of age, usually. I've seen kids as young as 3 with tics. Tics wax and wane. They're very variable. And in general, when I see motor tics tend to be very fast and rapid, very jerky looking, versus stereotypies are kind of more like flowy, is kind of a way to think about it. With stereotypies, there's no urge attached to these as well. So kids just don't feel it coming on, and it's much more harder for them to suppress it mentally. By far and away, the most common question that I get is it autism when kids have stereotypies? So this is a very, very common question that I get. Some clues is you can think about stereotypies with 2 main types of stereotypies. So one is primary motor stereotypy. So these are normal, developmentally healthy kids Oftentimes there's a family history of stereotypy, and these tend to start really early. So again, under 3 years of age, but usually I see these in kids start under 18 months of age. And so and there isn't a comorbidity associated versus secondary stereotypies. So these are the ones we think of more traditionally. So kids with autism, so all that hand flapping, probably made a lot of us think about kids with autism in a couple of those videos. Rett syndrome. So Rett syndrome, they get these stereotypic movements of hand wringing or hand clapping that tends to be very midline. Kids with developmental delay, so not just autism, but developmental delay in general, can often have stereotypy. And then I see a lot of stereotypies in kids with sensory deprivation. So meaning that they have hearing loss or hearing impairment or vision loss and visual impairment. So a good example that I often talk to families about is kind of Stevie Wonder with some of kind of his head movements or some of the rocking movements. Those are kind of stereotypies associated with blindness. So the major thing I do when I see patients with stereotypies are not harmful. They don't necessarily need to be treated, but making sure that I'm screening very carefully to not miss one of these other secondary causes. And you can do habit reversal therapy. There's only a couple people throughout the state that I know who are trained in this. It is very tricky to do outside of autism, but it is something that can be done. And there's new research that's being done, particularly at Johns Hopkins on this. The other question that I get oftentimes is with stereotypies is it a seizure? So some clues is with kids that you can distract them out of it. You can interact with them. They're happy or they're playful. It's happening when they're happy or excited, and it's the same thing over and over again. Those are all clues to me that I'm dealing with a stereotypy and not a seizure. All right, something different here.
All right, let's do a couple things first. Go ahead, put your hand straight out for me.
This is a patient I saw a couple of years ago.
We'll do it for 5 seconds. 1,
and he had this happen within a couple of days.
4, 5. Good job.
And you can see he's got these kind of movements back and forth.
Do the thing where you stick your tongue out and keep it there for 5 seconds. 1.
What I'm doing here is I'm seeing if he can stick his tongue out, and you can see his tongue keeps kind of moving, keeps darting back and forth.
Go ahead and squeeze my hand really tight here. 1.
His right arm is kind of doing its own thing.
4.
And that's, again, looking for motor impersistence, where I try to have him squeeze my hand and he kind of have these writhing movements here. So this is a good example of chorea. Chorea is these random appearing, you'll often hear kind of flowy movements or dance-like movements that go from one area to another. It can often worsen when kids want to move or want to act. So you can see when I had him do things, you can notice it happen a little bit more. And it can sometimes cause functional impairment. It often involves the face and the upper limbs. Sometimes kids just look restless or look like they just can't sit still. And they have this kind of lurching gait. So the 2 exam steps he showed really nicely in this video, that is a little bit more common with Sydenham's chorea specifically, is at the darting tongue sign. So that's, again, trying to stick out his tongue for 5 seconds. And you can see it seems like the tongue was just being pulled back into his mouth. And then the second thing is a milkmaid's grip. So this is having him squeeze and you get these kind of writhing movements around my hand. And with chorea kind of comes in 2 main forms. So one being primary chorea. So in kids with developmental disorders, often ADHD or other things, they may have this very, very slight physiologic chorea that isn't harmful. It's not going to cause functional impairment, but can be noticeable if you look very closely. And then the second thing is primary chorea. So this being benign hereditary chorea, this often runs in families and can be associated with thyroid disorder or a neonatal respiratory distress syndrome. Most chorea in kids tends to be secondary, though. The most common being Sydenham's chorea. So Sydenham's chorea being specifically associated with rheumatic fever. So when I see kids like this who come in with acute onset chorea, the very first thing I'm thinking about is looking for rheumatic fever, consideration of an echo, seeing if there's any signs of valve impairment. You can also see this with other autoimmune disorders. So I've had a patient recently who has concern for lupus. Antiphospholipid syndrome is also associated. We've seen chorea in patients with autoimmune encephalitis. And then the other major thing I would think about with acute chorea is drug exposures or medication exposures. Patients on stimulants, or that they've overdosed on them on accident. Those are medicines that can sometimes cause acute chorea, and then it'll go away. If you have a patient that you're really concerned about chorea, we should see them urgently. Another mimicker, so I'm actually going to stop talking about movement disorders for a second and talk about a mimicker that I see of Tourette syndrome a lot. And I'll say I probably get a couple patients a year that we thought had tic disorder, but actually had juvenile myoclonic epilepsy, or JME. So I'm going to talk a little bit about myoclonus. Myoclonus, myomuscle, clonus jerk. These are quick, very fast muscle jerks or muscle contractions. They're usually stereotyped, and you don't have urge. You can't distract them. You know, kids with Tourette's, kids with tics, normally if they have a right arm tic and then I make them use that right arm, it goes away. With myoclonus, it's going to be very persistent, no matter what I try to do to distract out of it. Myoclonus comes in a couple different flavors. So one being normal myoclonus or physiologic myoclonus. So a couple examples of this can be hypnic jerks. So if you've ever fallen asleep or your spouse has fallen asleep and then they jerk real bad and that wakes you up, that's a hypnic jerk. It's normal. Hiccups being myoclonus of the diaphragm is normal. You can have some primary myoclonus disorders, which are some genetic disorders that is usually a diagnosis of exclusion. Epileptic myoclonus. So anytime I see myoclonus that I'm really concerned is myoclonus, I'm always thinking very first trying to rule out that it's epileptic. And then you can see myoclonus associated with other disorders. So autoimmune disorders, you can see it with injuries to the brain, hypoxic disorders. You can see medicines that can cause it. So with specifically myoclonic seizures, so how in the world do I know that I'm dealing with a myoclonic seizure and not a tic? So again, some clues is these tend to be very repetitive, quick jerking. There is no urge. So if I get a 15-year-old who doesn't have vocal tics at all, they only have motor tics, it's only in the extremities, and it doesn't involve the face and the eyes. So you saw all of those tic videos, all of those kids had eye blinking tics or eye darting tics or head shaking tics. If it's just in the extremities, there's no urge, they can't suppress it. I'm worried about that being a myoclonic seizure until proven otherwise. The other clue is myoclonic seizures tend to be early in the morning. So you'll see kids happen much more in the morning. When I get EEGs, we're often trying to get it in the morning because that increases our ability to detect this. Oftentimes they'll tell me, hey, that they will throw objects or drop objects, or a couple kids I've had, they jerked so much in the morning, they actually fell to the ground. And that was kind of a clue that was what we were dealing with. If you have a patient that you're concerned for this, send them to us as quickly as possible to evaluate.
Your hands straight out for me.
So this is a patient with tremor.
I want you to put your hands up like this. Good, hands down like this.
Her tremor is a little unusual, and I'm going to talk about tremor, and we're going to come back to this video.
I want you to put your hands out again.
Specific things in this video.
Sure.
But tremor, by definition, means oscillation around a point. So this means that you've got a central point and you are kind of tremoring right around it. And when I see kids with tremor, the biggest thing is trying to kind of see when it happens and where does it happen. And so when should I be concerned about tremor? So these are the different ways we can divide up tremor based on when it happens. So rest, action, posture, intention, or task specific. So rest tremor in kids is never normal. Rest tremor can be a sign of Parkinsonism or something else. And oftentimes if I see rest tremor in kids or Parkinsonism in kids, it is medication induced until proven otherwise, often from dopamine blockers. The big thing when assessing for rest tremor is to make sure kids are actually at rest. So getting kids to relax is really hard. Oftentimes I have them put both their hands on their lap and then tell me like a plot of a movie or a TV show, just really try to distract him to try to get rest. And so rest tremor would not be normal. Action and kinetic tremors or posture tremors, these are all very normal. These are all very common. These are not something that is scarier to be red flag. I hope not, because I have some. You can see there just a little bit of a posture tremor that I have as well. And it's not uncommon to have tremor like that is a little bit worse with posture, with isometric movements, or doing action. What is abnormal is a tremor that is worse with intention. So that means not when I move that my tremor is worse when I move, but that when I get to a specific point, that's where we really start seeing tremor. Intention tremor is something that we need to evaluate. That's more concern for a cerebellar coordination problem that we need to evaluate a little bit more quicker. And then something we don't think about as much is task-specific tremor. So this means I only have tremor if I move my hand in a certain direction. When I see that, that makes me worried. Let's say I only have tremor when I move my hand this way and then it tremors. That makes me worried about a dystonia, that the body is creating a tremor because it's fighting against the muscle wanting to contract in a certain direction. So rest, intention, and task specific, those are 3 red flag symptoms that you should be concerned about. Tremor is classified in, I like to think in kids with 3 main types of tremor. Number 1 is enhanced physiologic tremor. So like I showed you with my tremor. So all of us have tremor all the time. Our body is constantly, when our hands are out, telling our hands, our muscles to contract and relax to keep our hands steady. And so we all have this very low lying tremor that you can't see. And there's a lot of things that can make tremor worse. So acute stress or fatigue can make that much worse. Oftentimes, if I've had 3 cups of coffee, which I try not to do, that will make that enhanced physiologic tremor worse. A lot of medicines can do this, as well as thyroid hormones, and I'm going to go through a list of medicines here in a second. Essential tremor. So essential tremor or familial tremor is the most common tremor disorder in kids. When you think about essential tremor, oftentimes people will think about this being in people more in their 50s or 60s, but most of the time it often actually presents more in teenage years. Essential tremor start unilateral. So most of the time when I see a unilateral tremor, that makes me a little, that could be a concerning feature, but essential tremor often will start unilateral, but within 6 to 12 months, it becomes bilateral. So when I see kids for tremor, I almost always, even if they have a normal exam, follow them up in a year just to make sure that there's no progression or worsening. And then the third thing with type of tremor is symptomatic tremor. So this means tremor due to something. So like a toxin, a medication, a structural lesion, or like a problem in the brain, or from a genetic disorder. So things like Wilson's disease, things like spinocerebellar ataxias. Most of those, I'm looking for other signs of ataxia. So patients who are having falls, or balance issues that's progressing, or problems with speech or swallowing. Those are other symptoms that, hey, may make me more worried about that third category, that symptomatic tremor. Medicines that can exacerbate tremor. These are really common. And when I see patients with tremor, the very first thing I'm trying to do is make sure that one of these things is not contributing. I see a lot of patients referred to me who are on SSRIs or on amphetamines or who have high caffeine use that makes a tremor worse. And then there's a lot of medicines that we use in neurology. Valproic acid. So one of my mentors likes to talk about, before we could get valproic acid levels regularly, they would just titrate valproic acid until there was tremor that appeared. And that's how you knew it was at a therapeutic dose, because tremor is just so common in patients on valproic acid. So this is a nice algorithm to kind of think about working up tremor. So first is rest versus action. And a rest tremor, again, never normal, needs evaluation by us if it truly is a rest tremor. And oftentimes the first thing we're going to see is, are they on medicines that can cause Parkinsonism, like a dopamine blocker, and valproic acid as well actually can do that. The second thing is it an action tremor? So when I see action tremors, again, I'm looking at medications, or they're things that we can wean. Sometimes if patients need them for psychiatric reasons, I'll just counsel about tremor if they are doing okay and it's not causing functional impairment. Sometimes they need the medicine. And so try not to wean it if possible. If that's the case, I try to talk or touch base with whoever is managing those medications. If it's a postural tremor, it's normal. And oftentimes only needs to be treated, again, if it's causing functional impairment. But if I see that intention, or I see any other signs of ataxia with, again, balance issues, difficulty with gait, falling, speech, swallowing issues, that's where we'll often get imaging. Medicines, if I treat essential tremor, I'll start with propranolol and primidone, and I'm just going to talk about those two quickly. But the key with these is, again, like we talked about with tics, go low, go slow. Propranolol particularly can be very sedating, or can make people just kind of worsen depression. So watch those very closely. So the last thing I want to do is talk about functional movement disorders. And so I'm going to go back to our video here, and we're going to talk about this a little bit more detail. So this was a girl I saw a couple of years ago who had this very acute onset tremor that developed within a couple of days. She also was presenting with non-epileptic spells, or what we used to call seizures.
I want you to put your hands out again. And I want you to take your left hand, and I want you to open and close.
And so I'm doing a couple of things with her tremor here. So you can see her tremor is not really around a point. It kind of changes. It goes up and down sometimes, side to side sometimes. And what I'm doing here is something called entrainment. So I'm making her do movements with her left hand.
I want you to take the left hand still, and I want you to tap.
You can see it here.
And do it fast. That
the tremor on her right hand changes speeds based off what I do with her left hand. So that's something called entrainment. So with functional movement disorders, how do I know this is what I'm dealing with? So functional movement disorders, what we used to call conversion disorder, we deal with a couple main things. One is variability. So that means, just like you saw in that video, the tremor changes a lot. Second is distractibility. So I get them to do something else and maybe the tremor goes away or lessens. And then 3, entrainability. So I can get you to do something. And this is due to kind of, I explained to families kind of the brain has learned a wrong movement that is done subconsciously that you basically just have to undo. We don't say conversion disorder anymore because only about 60 to 70% of patients have a specific underlying thing that they converted into their symptoms. So, and I've seen this sometimes just in athletes, or other things. So this is a really nice diagram of what functional neurologic disorder can look like. So oftentimes there's a triggering event. So maybe something happened or a minor injury, and maybe there's some underlying predisposing factors such as anxiety, depression, childhood adversity. But sometimes, again, you may find nothing. And then there can be other things that make that worse, particularly family situation or social situation. If this is what we're dealing with, and patients with this should be evaluated by us so we can make sure we're not missing something else. The number one way to treat this is getting the right diagnosis. Getting the right diagnosis, and if you have the right diagnosis, then getting buy-in from the parents, oftentimes both parents, or if there are other caregivers involved, all the caregivers involved, and getting buy-in from the medical team, as well as the patient. And then I often will talk about, we basically need to retrain the brain, or motor retraining, which is a combination of physical and occupational therapy with psychology. Now I want to talk about a specific, I'm going to do this quickly, but a specific functional disorder we've seen in the past year and a half.
So this comment gives me an opportunity to talk about functional tics, which is really important, especially now when TikTok tics are happening, and those are functional tics.
So this is referring to functional tic disorder, or you'll hear some newspapers call this TikTok tics if you read about this. These were patients we saw probably about 2 years ago, and we still have patients that show up with these that had very, very severe rapid onset tics that were really hard to control. And they would have many tics. And I mentioned earlier that coprolalia is rare, and I had rarely seen it until these patients started coming up. And about 50% of these patients will have coprolalia. And the demographics are different. So they tend to be girls ages 13 to 17. They tend to have other comorbidities. And the reason we call them TikTok tics now is, we recognized internationally, first published in the United Kingdom, that there was an association with all these kids and watching videos on TikTok of kids with tic videos. And we started figuring that out because I used her video because I've actually seen her specific tics, kind of that noise or bang bang, or a couple. I've seen those just repetitively in a lot of these kids, showing that they've kind of seen the same videos. Clues that you're dealing with this and not a Tourette syndrome is explosive onset, very, very frequent tics, 29 a minute in one study, and that's very common. As you can imagine, can be very debilitating, and it's much more common in the extremity or trunk, and they often have comorbid anxiety depression. So the way we treat this, medications almost never work for these. We tried, there's been a number of studies that have shown high doses tend to not work, but treating the underlying comorbid conditions if anxiety depression is involved. And then particularly at Spalding University, we now have a lot of experience of modifying CBIT to these patients and doing a combination of that with cognitive behavioral therapy. And then I've actually often recommended social media fast. So getting off Twitch or TikTok for 2 weeks. And almost all these patients, they improve dramatically and it goes away completely. So some takeaways. Movement disorders can often happen in kids. And as you saw here, video can be helpful. Knowing the type of movement helps with further workup. And then behavioral therapies like CBIT can be very helpful. And then the other takeaway is just know I'm here. Happy to see patients, happy to evaluate these kids and work together on them. Some overview of tics like we talked about. So tics with that urge, stereotypy is fixed movement, myoclonus very quicker, chorea is random, tremor, oscillatory, and then functional, those 3 things, and trainability, variability, distractibility. These are my references, and I'm happy to answer any questions that I can.
All right, thanks, Chris. That was good. A couple questions on Botox is not very reimbursable in the pediatric world. Will they reimburse for that in movement disorders?
So they will with Tourette syndrome, but I will do it very, very rarely. So I can think of, I see hundreds of kids, honestly, with Tourette syndrome, and I've had 2 that I've even thought about doing Botox on, and I think we've only done it on 1. It's used a little bit more in adults, and again, it's going to be much more for those ones that are more motor movements. I think of Botox or baclofen I'd mentioned too, with neck tics, like people developing a lot of neck pain with those. Sometimes it can be helpful. And then I work with PMMR typically on those, getting Botox for those patients.
Okay. And then, you listed a number of ways to test or treat motor tics. Would you suggest that the pediatrician start treatment, and then if it doesn't, work, they send them to you, or what do you think?
Absolutely. Definitely welcome to start treatment for sure. And I know a lot of people are very experienced with this and doing a really excellent job with this. The main advice that I give is just setting expectations. So that's the biggest thing I find with patients. So absolutely can be started.
All right, that's all the questions we have. So thank you, Dr. Barton.